in Barcelona.
Never mind. Okay, thank you. Welcome to this webinar. This is the first vascular webinar of the vascular session of the EANS. I'm Marco Cenzato, the actual chairman of the vascular session of the EANS. To my side, there is Dr. Enrica Fava, who is our neurophysiologist, a great and experienced neurophysiologist. We work with her. Then we will have as a guest Isabel Fernandez, who will talk, who is a neurophysiologist, a great neurophysiologist from Barcelona. And she will talk about neurophysiology in vascular, in aneurysma, I guess, or in vascular pathologies during surgery. And on the other side, we have Francesco Sala, who is the incoming president of the EANS, and he has a great experience also in neurophysiology. He is a neurosurgeon in Verona. So I think we can start. You know already that you can put question on the chat dedicated. So please send the question on the Q&A section of this webinar, and we will discuss at the end of the presentation. So please, Isabel, it's your turn. Thank you.
So thank you very much for inviting me. It's my pleasure to be part of this webinar. I try to do a very brief talk on this topic that I really like. I'm trying to share my screen. Let me see, here. Okay. Can you see my screen? No.
No, not anymore. We saw it for a short time.
I think it's because it's open in the last slide. You see?
Yes.
Okay. So I will open it. No.
No.
Let me go to the first one.
Yes, click the first slide and start the presentation.
But then
Click the button, the presentation button. It's on the wrong screen. No, you have another screen?
No. No. Now, right?
Okay, perfect.
Yeah, great.
Okay, so now I will open this and this. Okay, so I'm going to try to explain this topic that I really love in a very practical way. I hope you have questions later. If there is no time, you will see in the last slide, I'm giving you my email address. So please feel free to contact me or email me, and I wish to save all your questions. So yeah, so I will start with this brief introduction. As you know better than me, the intracranial aneurysm surgery is a complex discipline, and there are many factors that will influence on the difficulty and result of the surgery, like the age of the patient or the clinical status of the patient that can be evaluated with different scales, as you see here, and also the size of the aneurysm and even the morphology. So the goal of the surgery is to exclude the aneurysmatic bag from the normal blood flow. For that, many times we are going to need to place a temporary clip on the afferent artery to the aneurysm, and this is correlating with an unknown period of ischemia. And we are going to do that to clean up the aneurysm's neck before placing the permanent clip, which is the end of the surgery. So the temporary clip, as I said, is associated to an unpredictable time of ischemia, and here the IONM plays a very important role. I would say against to the idea that many neurosurgeons have, that vascular surgery is one of the type of surgeries where the IONM can be more useful. And I try to demonstrate it during my presentation. So we're going to do during this temporary clip time different modalities, different neurophysiological modalities. First, we're going to use SSEPs, somatosensory evoked potentials, that gave us information about the cortex. So it's going to identify cortical ischemia during the temporary clipping. On the other hand, we can also monitor MEPs, motor evoked potentials, that can be recorded after transcranial electrical stimulation or after direct cortical stimulation. And I will show you later on why it's important to do both of them.
Okay.
This is able to detect subcortical ischemia when the permanent clip is placed, because it's able to identify when a perforator artery, for instance, is accidentally.
È sottocorticale.
Anche questo.
This is our electrode montage on the scalp. You can see here that we are going to place our corkscrew. Those are placed on the motor cortex, and those are placed on the sensory cortex. So we are going to be able to monitor MEPs and SCPs since the very beginning of the surgery. Somatosensory evoked potentials are, with no doubt, the essential modality to monitor during the temporary clip. Why? Because if there is an eventual hypoperfusion due to the temporary clipping, we are going to see that the CPs go down because they are generated on the cortical level, which is the farther from the point where the temporary clip is. So the first thing that is going to be down, that is going to change if there is some hypoperfusion, will be the SCPs, the somatosensory evoked potentials. In this sense, one might think that only SCPs are enough and we don't need to do MEPs, because if I'm telling you that this is the first responses that is going to go down, then why are we going to use also MEPs? That is put a little bit more effort in making our methodology more complicated. So I will show you why it's also essential to combine both of them. In relation to motor evoked potentials, as you see in this schema, they are generated subcortically, okay, not cortically, but subcortically, so they are going to change a little bit later than the SCPs. We're going to use this paradigm of stimulation, which is a train of stimuli. This is the typical train that we use for anything in any type of surgery. And we can do it transcranially with these electrodes that I showed you in the previous picture, but also by direct cortical stimulation, that in this type of surgeries is really important. We are going to record the responses from different muscles, except especially from distal muscles from the forelimbs, because they have more representation within the corticospinal tract. So with this slide, what I want to show you is the importance of using direct cortical stimulation, not only in intracranial vascular surgery, but also in brain surgery, in supratentorial tumors. Why? Because if we use transcranial electrical stimulation, as you see in this picture, with these electrodes that are placed on the scalp, we will bypass all these areas. So if there is some hypoperfusion, some ischemia in this cortical subcortical area, we'll miss it. We are not going to see anything. So I'm going to tell the surgeon that everything is fine because MEPs are fine, since I'm stimulating below the region that is affected. For that reason, we need to use, or we prefer to use direct cortical stimulation, as you see here. We place the electrode right after the dura is open. So we have this type of stimulation, which is more superficial. Therefore, we need less intensity. Then the patient is not going to move in this critical part of the surgery where it's essential that the patient is just not moving. So with that, we are going to have real-time monitoring. So you asked me what is the ideal strategy of using this test of corticospinal tract or motor tract. I would say that it's necessary to combine both types of stimulation because they are giving complementary information in different parts of the surgery. So obviously we cannot do direct cortical stimulation at the beginning of the surgery because the dura is not open. That's obvious. So we're going to use transcranial electrical stimulation during the opening baselines right after the intubation. So with that, we have early evaluation of the patient, a preoperative evaluation. We are going to use C1, C2 montage that is a little bit closer to the midline. So with that, we get a more superficial stimulation, not like C3, C4. That is the one that I showed you in the previous schema. We can check also on the ipsilateral side of the body, and we will confirm the changes that we can record by direct cortical stimulation. So we have two methods to check the same thing. And when are we going to use the direct cortical stimulation? So obviously when they place the electrode on the motor cortex, we can take the baselines. As I told you, it's a more superficial stimulation. It needs low intensity, the patient is not moving, and this gives continuous monitoring and real-time monitoring, which is essential during the temporary clipping and during the aneurysm manipulation. You don't want your patient be jumping on the bed while I am checking the corticospinal tract. These are the conditions that are a must, they are necessary before placing the temporary clip. So the surgeon is going to ask us, is the patient ready for the temporary clip? And is not ready if we don't accomplish these three items. First, the patient has to have a high systolic blood pressure above 140, and this is going to be achieved by anesthesia team. They are going to give some vasoactive drugs to increase the blood pressure, just with the idea of compensating with collaterals if there is some hypoperfusion during the temporary clip. Then the second one is to achieve this bar suppression EEG pattern, because if we get these EEG patterns, this means that the patient is very well protected, that the brain is having a very low metabolism, so we'll be able to resist more an eventual hypoperfusion. And this is done by anesthesia and neurophysiology. So anesthesia is going to use propofol and not gases, because if they use allogeneic agents, they are going to block many synapses, and the responses from the neurophysiological point of view are going to be very small. So it's much better if we use propofol. And also, evoked potentials must be stable. Once we get these three things, we can tell the surgeon that the patient is ready and not before, so the clip can be placed. The protocol that we use, as you see in this table, we are going to use to record SCPs and MEPs from the four extremities, no matter the location of the aneurysm. But during the temporary clipping, which is the riskiest part of the surgery, we are going to focus on the modalities that can be damaged. So for instance, if we are working on the anterior cerebral artery, during the temporary clipping, we are going to focus on lower extremities, SCPs, and MEPs. If we have an aneurysm on the MCA, we are going to focus in the temporary clipping in the contralateral upper SCP and contralateral upper MEP. If we have the bad luck of having a basilar artery aneurysm, then we are going to check on brainstem responses such as the auditory evoked potentials or others. In cases of pica aneurysm, then we are going to add lower cranial nerves because they are potentially at risk during the surgical approach. The significant changes, we say that there are significant changes when the amplitude of the SCPs or the MEPs go down up to 50% comparing with the baselines. Then we are going to advise the surgeon to replace or to remove the clip in order to reverse our responses. So it's not that we just check the change and don't do anything. We are very active, and we tell the surgeon to remove the clips, and the responses come back to normal, and this means that the patient doesn't have any infarct. This slide is just to show you a little bit the how it goes. No, you can see on the left side the surgical steps, and on the right side the neurophysiological steps. So we start with the electromontage, we take the baselines, then the craniotomy starts, they open the dura, they place the electrode on the cortex. We are monitoring continuously while they are identifying the aneurysm, dissecting the aneurysm's neck. They put a temporary clip, and we are monitoring continuously that everything is fine during all this manipulation. We are especially focusing on MEPs when they put the permanent clip, because we can have the problem with perforators and so. And during the clipping verification with different methods, we are also doing continuous monitoring to check that there are no vascular problems. These are just fast three examples of the three situations that we can see with changes in evoked potentials that are correlated with different vascular problems. So this case was a left MCA aneurysm. You can see here that we were monitoring right median SCP and left median ECP. So this was the essential one. This is the one that can change during the temporary clipping. So the surgeon put the temporary clip, and 5 minutes later, you see that the response is getting flat while the other is normal. So in this case, we told the surgeon, listen, the temporary clip is not, or the patient is not tolerating the temporary clip, you need to remove it. And he did it, so the response came back to normal. This can happen several times during the surgery, but the goal is not having a brain infarct, so it doesn't matter, we have to wait a little bit. with this schema, what I want to show you is the importance of doing motor evoked potentials in this type of surgeries. I told you that SCPs are the first showing changes when there is hypoperfusion, but there are some situations where when SCPs are fine, but MEPs are not fine at all. So if you have this schema with the aneurysm, we take the baseline, everything is fine, CPs and MEPs, fantastic. Here we place the temporary clip, and here we're going to focus on SCPs, as you see here, because they are generated at the cortical level. So if there is some problem, some vascular problem due to the temporary clip, we'll see that the SCPs go down. But what happens in this situation? If accidentally a perforator artery is located on the aneurysm's neck, and the surgeon doesn't see it because it's not that easy, as you better know than me, sometimes you don't see this perforator. So if you put the clip here, you'll see that the MEPs go really down because these arteries go to the internal capsula. So you will have normal SCPs, totally normal, but MEPs are off. So if you don't do MEPs in this case, your patient will wake up with a motor deficit and it can be avoidable. And this is one example. So here, there was a right MCA aneurysm. We were monitoring left median SCP and left hand MEP, and I want you to see what happened in this case. So this is the cascade of responses during several minutes of the surgery. During the baselines, you can see here normal SCP, normal MEP. They put the temporary clip for 10 minutes and everything was fine. They put the permanent clip and look at the MEPs, what happened. They change the morphology, they start going down in amplitude, while the SCPs are totally normal. So we told the surgeon, listen, look at the permanent clip, something is wrong. He looked, he removed, and he saw a little perforator artery that was accidentally clipped with the permanent clip. So he just repositioned the clip and the responses came back to normal. So with that, we knew that the patient was going to wake up fine. And this is the last situation that we can see when there is it's not related to temporary clip or to permanent clip, but we still can have changes for other reasons. So here there was a left MCA aneurysm, and here we have the right hand MEP. So you see these are normal responses. They open and everything was fine. They put the temporary clip and permanent clip and everything was fine. And here the responses started going down. So we told the surgeon, he removed the clips, all clips, temporary and permanent clips, and the responses didn't go back to normal. Worse, they got worse. We lost them completely. So what could be the cause of this loss of MEPs? So at this moment, we identified some vasospasm and we just applied papaverine to the surgical field, and the responses came back to normal. The only difference, if you look at the field, was the diameter of this artery that went from here to here, and the responses recovered immediately after that. So if we go to the literature, as I started saying, it's a very controversial topic, and there are surgeons who really don't like to use or don't think it's useful to do intraoperative neuromonitoring in these type of cases in vascular surgery. But I want to show you with this publication, or at least this is our experience, that this is not true. So this is an article published in Journal of Neurosurgery in 2019, where they concluded that the IONM doesn't make any difference in the outcome of patients undergoing surgery for aneurysm, intracranial aneurysm clipping. So they included 272 cases. Half group was non-monitored and half group was monitored. They found 18 deficits in each group, the same number of deficits. They found significant changes in evoked potentials in 18 of them, but only 5 were true positive and 12 were false positives. And they also had no significant changes, but new deficits in 5 patients. So these were 5 false negatives. So at the end, the conclusion of this paper was that the assumed positive impact of IONM in aneurysm surgery didn't reach significance, and that from the medical legal point of view, IONM is not useful in neurovascular surgery. But if you carefully review the methodology described in this paper, they were using gases, which affect clearly to the responses from the very beginning. So probably the responses were already during the baselines very small and difficult to evaluate from the point of view of changes. They didn't use direct cortical stimulation, which, as I show you in several slides, is very important to be focal and to avoid false negatives results. And they use a very deep stimulation montage, C3, C4, so they were for sure bypassing these superficial levels where the cortex can be suffering from ischemia. So there is later another paper published in 2022, and this is totally the opposite. So the previous one didn't use direct cortical stimulation, and this one said that they just use direct cortical stimulation and nothing else. For that, we wrote a letter to the editor because in our experience, all methodologies have their importance. So we think it's needed a multimodal protocol. So SCPs will be able to detect, as I showed you in previous slides, cortical ischemia during the temporary clipping, but direct cortical stimulation will show us deficits at the cortical level during the permanent clip positioning. So this is our article published in Neurosurgical Review in 2022, where we evaluated two groups of patients undergoing surgery for aneurysm clipping. So our number of patients is very similar to the one described in the German group. We are including 268 ruptured and unruptured intracranial aneurysms surgically treated. We monitor 180 patients, so 67% of them were monitored. We didn't monitor 88 patients, and we use multimodal IONM protocol. According to our results, there was a significant difference with a reduction in perioperative strokes and better motor surgery-related outcome in patients undergoing IONM. And the last conclusions were that longer temporary clipping time, larger aneurysm size, and the non-use of IONM could be considered as risk factors for ischemic complications during microsurgical clipping. But despite these conclusions, I would like to show you a little bit more in detail our results. So we found the independent risk factors for ischemic complications: time of temporary clipping longer than 6 minutes and 5 seconds, aneurysm size bigger than 7.5 millimeters, and the non-use of IONM. Surprisingly, the aneurysmatic rupture was not identified as an independent risk factor. We found changes in IONM, SSCPs, and MEPs in 52 patients. Only in SSCPs, isolated SSCP changes in 23 patients, MEP changes in 19, and combined changes in SCPs and MEPs in 9 of them. 29 of the changes were correlated to temporary clipping and 17 with permanent clipping. So we applied the recovery maneuvers that are clipping removal, review of the clips that were the permanent clips, blood pressure control. We wait until recovery, and we put some papaverine if we think that the cause of these changes is due to some vasoconstriction, vasospasm. So the ischemic stroke and surgical perioperative complications in our patients with and without monitoring, I would remark these data from our results. So we had ischemic stroke in 8.9% of cases that we monitored, but in 20.5 cases that were non-monitored. And we got permanent motor deficits in 5% of patients undergoing monitoring and 14% in patients not monitored. Despite this methodology, of course, you know that they are not perfect series, so sometimes we have new deficits despite the methodology, the multimodal protocol. So we found that these false negatives that we had with deficits were correlated with ischemia at the supplementary motor area. So in this case, the presence of MEPs at the end of the surgery means that the patient is going to be fine, so it's going to recover, so it's also good to have them. Also, in some cases, we couldn't place the grid, so we were doing only transcranial electrical stimulation. So in this case, obviously, we didn't totally trust our MEPs because we could be bypassing this cortical subcortical area. Also, we could have neuropsychological or cognitive deficits that we are not able to monitor. And in this sense, I want also to remark the importance of combining IONM methods with non-neurophysiological monitoring methods, like could be the ultrasound Doppler or the ICG video angiography, or the use of intraoperative arteriography, just to look at the areas that we are not able to evaluate during the surgery. So just my conclusions, I would say that the potential risk factors for ischemic complications are long temporary clipping, big aneurysm size, and the non-use of IONM. We also believe that tailoring a standard protocol with multimodal IONM is very important, and the combination of SCPs and MEPs during temporary clipping offers information in real time about the functional integrity of sensory motor pathways and this allows the surgeon to change the strategy and avoid brain infarcts. So in our experience, the IONM clearly correlates with better functional neurological outcome in this type of surgeries. And last, if you allow me just 5 seconds to announce the meeting of the ISIN that I'm pleased to organize at the end of this year. We are going to give some talks that I consider are very important because are related to communication between neurophysiologists and neurosurgeons during the operation room, which is the clue for a successful teamwork. And also we're going to include, I think 1 hour and a half, I think Francesco can clarify that, of a joint meeting between EANS and ISIN, also to work on this communication topic. And that's it. Thank you very much.
Well, thank you very much. Excellent presentation. I think we will ask for a while. We will have the question at the end of the presentation, also from Francesco, because there are some questions. We do have some questions, so I think it would be better to have all at the end of this presentation. So if you can stay, Isabel, we wait until the end, and then now I will let Francesco Sala do his presentation. Thank you, Francesco.
Thank you, Marco. Let me try to share my screen first. Okay, can you see my slides?
Yes, yes.
Okay. So good afternoon, and thank you, Mark, and thank you to the Vascular section for this opportunity. I'm very pleased to contribute to this webinar. Although I have to say that I was a little bit reluctant at the beginning, mainly because my first disclosure is that I'm not an interventional neuroradiologist and not also a vascular neurosurgeon. So I don't have personal experience to comment from the surgical or the neuroradiologist perspective, the value of these techniques. The second comment is that I was involved mainly in this many years ago when I was doing my training in New York. And for many years thereafter, it looked like there was not much interest from the neuroradiologist side towards the use of neuromonitoring. However, in the last 5-6 years, there have been a resurgence of papers dedicated to the use of neuromonitoring and provocative tests during the vascular procedures. And considering also that more and more vascular neurosurgeons are directly involved in endovascular procedures, I thought it could be valuable to our community to share this vintage presentation, which refer again to some old work, but I think can still be valuable. And then we will focus on some of the most recent presentation. So what happened when I was in New York 20 years ago was that at the place where I was training intraoperative neurophysiology with Dr. Delitis, there was this gentleman here by the name of Alejandro Bernstein. Bernstein was at that time one of the world leader and guru on the field of endovascular interventional neuroradiology. Yasunari Nimi was his associate at that time. And so we were seeing many patients coming from all over the world to New York to be treated, particularly for intramedullary spinal cord arteriovenous malformation. Bernstein was probably the one who published the first paper on the use of, at that time, somatosensory potentials, which after some years then was clear were not enough to cover for the sensory motor pathways during these procedures. But the main point is that they were looking for some help to make sure that these endovascular procedures were as safe as possible for the patients. So the main experience in New York was based on spinal cord EANS. Now, it's interesting that the first definition of a spinal cord EANS was by this German pathologist, Dr. Gaupp, who at the end of the 19th century described the spinal cord EANS as a hemorrhoids of the pia mater spinalis. And this funny description, however, reflects the fact that that author had some insight on the pathophysiology of this malformation, because as we know, the problem here is that you have a lack of the capillary bed between the arterial and venous compartment. So you have venous hypertension who can end up in spinal cord hemorrhages, but also you have a decreased spinal arterial perfusion pressure, which will cause spinal cord ischemia. You can have venous thrombosis and vascular steal phenomena, which also contribute to spinal cord ischemia. Now, the goal of the therapy obviously is to occlude the nidus of the AVM, but you can apply the same principle to maybe fistula or to devascularize a spinal cord tumor. And you have to do this preserving the blood supply to the normal spinal cord. Now, at that time, Bernstein preferred to perform these procedures under general anesthesia, which is also nowadays a preference of many interventional neuroradiologists, because the patient is much more stable. It's easier to see also the tiny vessels on the spinal cord. You don't have movement during the angiogram and the treatment. So the only way to assess the neurological function under general anesthesia was through neuromonitoring and provocative tests. A wake-up test was considered quite uncomfortable for the patient and also was delaying any intervention. So we systematically did this procedure with intraoperative neurophysiology and with the use of pharmacological provocative tests. Just to refresh for the trainees, the value of SCPs in assessing specifically the dorsal column pathway, so in terms of vascularization, the territory of the posterior spinal artery, while the MEPs reflect the cortical spinal tract, and therefore the territory of the anterior spinal artery. But we have to keep in mind that these two territories are connected by the so-called vasocorona, which is an anastomotic network which connect the anterior and posterior circulation in the spinal cord. So in terms of somatosensory potentials, these were done in the classical way, stimulating from the posterior or the posterior tibial nerve or the medial nerve and recording from the scalp. While for the MEPs, the possibility to use the D-wave, which, as you know, is the best predictor for the long-term motor outcome. But this was abandoned mainly for two reasons. First of all, because, sorry, just 1 second, because I think there is something, yeah, sorry, wrong with the presentation. So the use of the D-wave was not considered safe for endovascular procedures because these patients receive quite an amount of heparin, and to monitor the D-wave during endovascular spinal cord procedure, you would need to place an epidural catheter using a 2 needles percutaneously. So this will expose the patient to a substantial risk of a spinal hematoma. And so we were only monitoring muscle MEPs. But there is another reason which has to do with the mechanism of spinal cord ischemia. So there are quite several data from the experimental standpoint in the aortic occlusion models, which showed that if you have spinal cord ischemia, the peripheral nerve response is much more sensitive than the spinal cord to cord ischemia, which means that the muscle MEPs will disappear earlier than the D-wave. The gray matter is also more sensitive than the white matter, and it has been shown very clearly in dogs that if you have a spinal cord ischemia, the peripheral muscle response will disappear much earlier than the spinal epidural MEPs. Therefore, the monitor of the D-wave, besides the risk, wouldn't add much in terms of safety because the D-wave change will come after the muscle MEP changes. So general anesthesia, totally intravenous, avoiding bolus and avoiding allogenated agents and muscle relaxant after intubation. This is the traditional TIV approach that we have nowadays when it comes to neuromonitoring. But I would say that particularly for this procedure, to have a very stable anesthesia is extremely important, probably more than for any other neurosurgical procedure where we use neuromonitoring, and we probably discuss this later on. So this was the endovascular protocol. First of all, the identification of the anterior and posterior spinal artery territories supplying the normal spinal cord below and above the AVM. Then the second step was to identify the angioarchitecture of the AVM, followed by the selective catheterization of the pedicle artery, and then a super selective catheterization of the radiculomedullary artery feeding the nidus of the malformation. Then when the neuroradiologist has placed the catheter in the position from where he would like to embolize the AVM, at that point, you perform the provocative tests. So the provocative tests are based on the pharmacological properties of two drugs, mainly a low dose of amytal, which is a short-acting barbiturate, which selectively blocks the gray matter, so the neuronal activity, and a local anesthetic like lidocaine, which selectively blocks the white matter function, so the axonal activity. Therefore, combining amytal and lidocaine, you can selectively block both the gray and the white matter, and therefore test for both territories. At that point, so here is just a schematic cartoon to illustrate what happens. So if your catheter is not selectively in one feeder which goes to the AVM, the provocative drug will diffuse to either the white and or the gray matter, and therefore you will have a positive provocative test with either disappearance of the muscle MEPs or significant drop of the ACPs. While if the catheter is selectively in a feeder which goes only to the nidus of the AVM, you will have a negative provocative test with no changes in the evoked potentials. And this is another example. If you are not super selective, you will have a positive test. If you are very selective, you will have a negative test. And so at that point, provocative test was done. If it was negative, embolization could proceed. If the provocative test was positive, no attempt to embolize from that specific catheter position was done, and the attempt was to be more selective with the catheterization or to approach the AVM from a different feeder. At that point, the provocative test was repeated again. If it was negative, it was possible to proceed with embolization. However, if the provocative test was repeatedly, consistently positive, then embolization was abandoned. So in those years, we published quite a few papers using these techniques, which was very fascinating and quite elegant also from a neuromonitoring standpoint. Probably the most important publication was the one which appeared in the American Journal of Neuroradiology, where we look at a series of 52 patients with spinal cord AVMs, where we perform 84 procedures and a number of provocative tests with both amytal and lidocaine. Now, as you can see here, for the provocative tests, we had 8.5% of positive tests with amytal and almost 27% of positive tests with lidocaine, which reflects the fact that it's much higher the chance to block the white matter than the gray matter. That explains why we had more positive result with lidocaine. But also, please notice that with only ACPs, we would have had just one positive provocative test, while most of the time we had changes in the muscle MEP. So it is of paramount importance to always monitor both the ACPs and the MEPs, and if you have concern about the conus, also the bulbocarbonous reflex. The other consideration is that if you look at the vessel where the provocative drug is injected, again, we have some changes in the MEPs injecting the lidocaine in the anterior spinal artery, but also in the posterior spinal artery. So you cannot just make an assumption that because you are dealing with the posterior spinal artery, ACPs will be sufficient, or with the anterior spinal artery, the MEPs will be sufficient. Because again, as I mentioned at the beginning, there are the so-called vasa corona, which represent a network between the two territories. So the only way to be 100% safe is to monitor both ACPs and MEPs, regardless which is the vascular territory the interventional neuroradiologist is dealing with. So when I came back to Verona, we tried to extend this experience also to the treatment of brain AVMs. That was a small experience with about 10, 12 cases where we used basically the same approach. So we look at 11 patients with brain AVMs. 3 of them had partial motor deficit on admission. 4 of them had previous embolization without the use of neuromonitoring. The AVM were either pre-Rolandic, Rolandic, or post-Rolandic. And in total, we performed 21 procedures with provocative tests. So the principle is the same. You run MEPs and SCPs. When you are ready to embolize, you check your potential. The expectation is that if you are selectively into the in one feeder, which goes only to the nidus, you should have no changes in the potential, therefore a negative provocative test, which you will allow to continue with embolization. While if you are not selective enough, some of the provocative drug may diffuse to normal cortical, subcortical tissue, and you may have changes in either the SCPs and or the MEPs, and therefore you will have a positive provocative test and will not be safe to embolize from that specific position. So this was an example of a 12-year-old right-hand girl who came in with this bleeding AVM. This was the preoperative angio. These were the evoked potential. So we look at the MEPs from the contralateral side, upper lower extremity and facial muscle. These were the baseline before the lidocaine injection. Potential were quite stable. This is 2 minutes after the lidocaine injection. Again, no changes in the MEPs. Therefore, the embolization was performed. And this was 3 minutes after a glue injection. Again, no change in the potential. So she remained very stable throughout the procedure. The closing MEPs were very good. So it was possible to embolize some of the feeders to this Rolandic AVM with no neurological morbidity. These were the postoperative MEPs. Unlikely from this case, I apologize for the very old images. This was a young lady with left basal ganglia AVM. This was again the provocative test with lidocaine injection. So we were able to monitor the MEPs from the biceps and the forearm muscle, the extensor digitorum communis. So this was a baseline, very repeatable MEPs. But just 30 seconds after the injection of lidocaine, you can see that there is a complete disappearance of both responses. These are just the stimulus artifact and some spontaneous firing from the muscle, but there is no MEP here. And the MEP started to recover about 5 minutes later when there was the washout of the provocative drug from the vascular system. So you start to see some returning of the MEPs here, and they were fully back about 7 minutes after the provocative test. So in that case, obviously, no embolization was obtained from that position. So in total, we had 15% of positive provocative tests. We used only lidocaine because Amital was not available in Italy at that time. And we had some provocative tests, 7 positive MEP response and 2 positive both MEPs and SCPs. So the embolization was performed only in the 49 feeders with a negative provocative test. We didn't have any SCP or MEP changes at the end of the procedure. 3 patients had some transient sensory motor deficit, 1 lower limb paresthesia, 1 facial weakness, and 1 arm paresthesia and weakness. But they were all transient. Within a few days, they had a full recovery, and there was no transiently severe, neither permanent treatment-related morbidity. Now, for many years, when I came back to Verona, looking at the literature, it was very rare to find papers dealing with this use of neuromonitoring during endovascular procedures. This is a paper from 2014 from Spain. And in their discussion, they refer to a paper by Paulsen, who used this provocative test in awake patients, and to our paper from 2007, saying that basically after that publication, there were no other reports on the use of SCPs and MEPs during embolization under general anesthesia, which is quite surprising because it looks like for almost 10 years, no one was more interested in this strategy anymore. In this paper from Spain, they had 12 patients with both spinal cord and brain EVMs. They had a provocative test, which was positive only in one case using lidocaine. And this was the patient with the positive provocative test. As you can see here, they inject lidocaine at 11:15. This was during the endovascular treatment of MCA aneurysm. 1 minute later, there was a decrease of the MEPs, which completely disappeared 2 minutes later, and they come back about 15 minutes later. They also had 3 other cases where, regardless of the provocative test, there was a disappearance of the MEPs and the SCPs during the procedure. In 2 of these cases, they couldn't find any obvious angiographic findings which could explain the changes in the evoked potential. However, they decided to stop the embolization. The patient had no neurological deficit, but of course, here there is a question mark whether or not this could have been a false positive result. 2019, another paper by the Stanford group. Again, here they use SCPs, MEPs, and auditory evoked potential for intracranial AVM and AV fistulas. You see the negative predictive value was very good. They had no deficit whenever the provocative test was negative. So the conclusion of that study was the pharmacological provocative test can be performed under general anesthesia using neuromonitoring modalities. The specificity for the provocative test was 100% in both the awake and the asleep setting. And therefore, they concluded that it is safe to use provocative tests under general anesthesia as a valid alternative to perform these procedures in the awake setting. This more recent paper from China in 2021, again, they refer to our old paper about the use of general anesthesia and to the recent paper that I just showed you from Bican. So again, very anecdotal report still. In this study, they performed more than 100 provocative tests for 48 endovascular treatment in 22 patients. And again, they had only 1 out of 48 embolization with negative provocative tests where they had a problem with a postoperative hemorrhage. But other than that, in all the other cases where the provocative tests were negative, they safely embolized the patient and there were no neurological deficit postoperatively. They use, instead of using lidocaine, they used propofol as a provocative test drug, tailoring the amount of propofol depending on the size of the vessel. So it was a slightly different approach. But in the end, with the super selective catheterization and the provocative test, they were able to perform the embolization in all the patients in this series. So they concluded that negative predictive value is similar under awake and asleep with the provocative test setting. Obviously, this is an important observation. If you want to test higher cortical function like language or cognitive function, there is no alternative to waking up the patient because under general anesthesia, this would not be feasible. And the main point is that since whenever the provocative test is positive, we do not proceed with embolization. Of course, there are no data on the specificity of this strategy, so we cannot really check how many false positives we have. So I will conclude just saying that probably during this endovascular procedure with the use of monitoring, communication within the team is essential. It is always essential when you perform neuromonitoring, the communication between the monitoring team and the surgical team. But I would say for this specific procedure is really of paramount importance, because the interpretation of the provocative test is very much dependent, first of all, from a very steady state anesthesia, because if the anesthesia is not stable, small changes in blood pressure, for example, or in the drug concentration can provide slight modification of the potential that can mislead you during the interpretation of the provocative test. So you have to stay with a very stable baseline in order to interpret correctly whether or not the potential change after the provocative test. And also you need very skilled neuroradiologists because they of course have to be very careful in performing the provocative test exactly from the same position where they are supposed then to embolize, because otherwise you may have the diffusion of the provocative drug to other territories, which will give you a false positive result. And you may end up denying an embolization to a patient where it could have been probably performed safely. So the communication between the three teams is essential, because from this, of course, will depend the outcome of the patient. So I would stop here. Certainly you need a close partnership between the neurophysiologist and the interventional neuroradiologist. I hope, and I will be happy now to open the discussion to understand whether or not this approach can be still valuable nowadays. It seems so looking at the literature, but it was quite interesting for me to see that for many years, there was not much interest from the interventional neuroradiologist community towards the use of these techniques. And my last slide is just to invite all of you, of course, to Sofia. And as Isabel said, also to Barcelona. We are trying to strengthen more and more the liaison between the EANS and the ISAN. And so please come to Sofia, to Barcelona. I hope to see you there. And I will stop here and I'm happy to take any question.
Thank you, Francesco. Very, very interesting. I never had experience about this. Really something very interesting. And I think although maybe in the brain AVM now we have a very selective deep embolization. So we try to reduce the nidus embolization, but I think it's very important what you said on a spinal cord AVM, which is something that still has been is done by the endovascular, but introducing this methodology, I think it would be extremely useful. I don't know why they don't use it, but I think they need to be aware about this fantastic methodology you present. Do you have any comment, Marika?
No, I'm really interested in what happens during neuroradiological treatment of AVM and of any vascular lesion. But when I asked the neuroradiologists, they told me that their maneuver are not are all or none. So when they start, that's already done. If a damage must ensue, it is done. This is not true, according to your presentation. So they don't even, until now, they didn't consider the possibility of doing provocative tests, which is the key of your presentation, and I think the key of the success of this work. So we will try again to ask them. Second question to Isabelle. I'm very happy that you can have your anesthesiologist keeping the patient at a pressure of 140. We never get it. We try to arrive to 100, 110 maximum. So what argument are you using to convince the anesthesiologist to keep pressure so high?
No, actually, I don't have to say anything. They know it
depends on the anesthesiologist.
No. I mean, we are working always with the same neuroanesthesiologist team, so they are very used to manipulate
course.
these neuroactive drugs. So they are used to play around with these complicated cases. Actually, what is written is that you need to, before the temporary clip, you need to get 10% higher your blood pressure if you compare with the normal blood pressure of your patient. But we prefer to go higher if possible, and we used to go up to 140. Sometimes it's true that it's difficult, and we just settle down with a little bit lower in the, blood pressure, but the other factors has to be there. I mean, you have to be bar suppression, you have to be stable evoked potentials, even if you don't reach this 140, that is ideal, but obviously not always is possible. Most of the time it is, because they are used to manipulate these drugs, and we get this intensity.
Yes, the secret is to use vasoactive drugs.
Yes, they do.
Yeah, absolutely.
Actually,
we missed this.
The issue is when the neurosurgeon is approaching the aneurysm, so he asks us to get ready for the temporary clipping. So the anesthesiologist at this moment already starts trying to increase the blood pressure, and he or she starts already to increase the perfusion of propofol, that you know that it goes in opposite ways. If you increase blood pressure, propofol blood pressure goes down, so they play around to obtain the ideal situation. So like half an hour before or even more they reach the aneurysm's neck, or they start the dissection of the aneurysm, they already ask us to be ready for that. You know, so we are already communicating. So they ask us if the patient is already in bar suppression. They are increasing the propofol, always increasing the perfusion, not giving boluses, because this is also affecting the evoked potential.
Sure.
But nevertheless, you have 1/3 of the patient with a modification on the temporary clipping, or did I read it correctly? Because 1/3 of the is not our experience.
No.
Because in my experience with Marika, the impression is that in the main message is nothing is happening, so keep calm, you have all the time you need.
Exactly.
This is not so. In, let's say, 90% of the cases, so. There is no alarm, and so I think that one of the main message I perceived from the neurophysiological monitoring is not something that gives you alarm and more, let's say, anxious messages, but the main message is don't worry, everything is going fine. And this is, I think, is something that allows you to keep the temporary clip more than you were thinking without, that you can do whatever you want and nothing is happening. So this is, I think it's a main message in this kind of surgery. So
I totally agree with you. Actually, and what I said is that we had 29 changes out of 180 patients, so it's much less of 1/3. We don't have so many changes during the temporary clipping period. And the message is exactly as you said. So the temporary clip is telling us that the functional, the function of the nervous system is fine because we don't have any change, so you can go ahead. There is no need to remove the clip every 5 minutes because you don't know what's going on. You know that everything is fine during the temporary clip. So if your patient needs longer clipping, like 10 minutes or whatever, as far as everything is fine from the evoked potential's point of view, the patient is fine. So that's, I totally agree with your message.
And Francesco, do you have any experience in neurophysiological monitoring during AVM surgery on the other side?
No, we have done it, I would say, occasionally, but not systematically. You know, if you have some eloquent area, we have done MEPs, SCPs, but not systematically. The one comment about the interventional neuroradiology, asking to Marika, is that it would be interesting to have, I tried to discuss with them also recently, it depends also on the material they use to perform the embolization. So at that time there were glues, there were coils, there were onyx particles. So for example, if you use something which is not supposed to enter very small vessel, obviously the provocative test can enter any vessel of any size, while some of the embolizing material is of bigger size. So in that case, they would not worry about a provocative test which is positive, because they know that the embolizing particles will not enter those small size vessels. But so I think there are also some technical details from the neuroradiology standpoint, which affects the reliability and the need or less need for the use of these techniques. I don't know if nowadays, I mean, I have to say that looking at the literature, there has been again an interest for this technique in the last 6-7 years, which disappeared for almost a decade. So this tells me that there is probably more interest now again. I have to say that from a neuromonitoring standpoint, it's a very elegant technique, and also very fascinating, the possibility to mimic, because basically you can anticipate the result of the embolization in a safe way. And so with some limitation, but I still this can be a very valuable approach for performing the vascular procedure.
Extremely interesting. I agree. I didn't know that this option of provocative test, I think it's really something very valuable.
I remember that Bernstein, he had a huge experience. He didn't like to use it for brain EANS, probably because he was more worried about false positive. I mean, you know, that the cerebral hemodynamics is certainly more complicated than the spinal one. So the possibility that you may have some of the provocative drug going somewhere and giving some changes in the potential without necessarily being risky for the embolization is higher. So I think that was probably the reason why he didn't use it so frequently for brain AVM as he was doing systematically for spinal cord AVMs.
Mm-hmm.
But I think it's a topic of interesting discussion with the neuroradiologists for the years to come.
For sure. I think that it's very important to. This is a recorded webinar, so I think we have to get them in front of it and present it to them, because I think it's very important. We have some. I think it's almost 1 hour, so I think we have to close. But I think we have to pose some question we received. So
there is one question asking what is the normal amplitude and latency in MEPs. So the answer is the confrontation of MEPs is within the patients with the with the basal MEP before the maneuver that put the vessel at risk. So what is not the beginning of surgery, maybe not the opening, but just before the dangerous maneuver by the surgeons. So, and the other question is, what is the best ratio of bus suppression for aneurysm? This actually, I don't know. So I don't know when there is literature saying at what level of bus suppression we must arrive. What I see it's happening in neurosurgeries is bus suppression with pause lasting between 5 and 10 milliseconds. So I don't know your experience.
No, yes, yes, one burst per each screen. And the screen epoch length is about 5-10 seconds.
Yeah, 5-10 seconds, yeah, pause. That's what I use. So when I see the tracing becoming almost continuous, I warn the anesthesiologist usually.
And then there is a question for Francesco Sala. Thank you for the great talk. I want to ask you about your reasoning for not using D-Way deep wave for spinal cord AVM. I understand that there is a risk of hematoma with insertion of the D-wave electrode, but I would have thought that MIPs recorded in peripheral muscle dropping before D-wave is affected would suggest that D-wave is more reliable than MIPs for detecting true potential permanent injury.
No, so the problem is that the MEPs are more sensitive, the muscle MEP. So if you have a spinal cord ischemia, the muscle MEP disappear way before the D wave because the white matter tracks are more resistant. Therefore, you know, if you wait for the D wave to disappear, you may end up already with a severe ischemia, and the possibility to reverse that with any corrective measure will decrease. So in other words, using the D wave would not add anything to the value of muscle MEPs in understanding that there is an ongoing spinal cord ischemia, and therefore you have to take countermeasure to avoid that, you know, injecting papaverine or increasing blood pressure or whatever. I hope this was.
Do you have Ferris? Do you have any comment?
From my side, it was an amazing talk from both of you. Maybe yeah, I was familiar to Professor Sala's work on endovascular or on monitoring for endovascular procedures through a presentation from Professor Andrea Selenier some time ago. She mentioned this, and I found this very interesting, and I actually did read about it some time ago. And it's very interesting that we're sitting here talking about this today. And I even asked a little bit around, you know, like, colleagues, what do you think about this? And people looked at me with round eyes, like monitoring and endovascular. But I think the greatest obstacle we're seeing is just maybe a resistance to do it. But there's no real reason. I mean, there is evidence it did work, and it still should work in the future. And I think it would be very interesting to see if we can reactivate this with our respective neuroradiology teams. It's definitely something to be looking at in the future.
Yeah, there are some practical problems sometimes also because the angio suite is full of machines and equipment. So sometimes it can be a nightmare to have readable potential because of the artifacts. This is one point. And of course, it may delay also the procedure. So sometimes this is not very well received by the radiologists. But I think that for a high risk AVMs, this is certainly a strategy that may improve the safety.
But also the same way neuromonitoring was received with resistance at the beginning of neuromonitoring in operative neurosurgery. So,
but I think also could be the same because the same negative message that monitoring is perceived, and normally many neurosurgeons say, no, monitoring is something that disturbs me. While, as I said before, the main message is a positive one rather than a negative one. So I think that this is something that many neurosurgeon and probably also radiologists, they didn't realize that in main message. So I think we have to close. We have received many thank you, many compliments, great talks. Thank you. Thank you for the great talk. So compliments to both of you. I think we had a very large number of people who attended because we had more than 130 attending, so I think it was a very positive and good webinar. So thank you to both of you, and
thank
hope
you.
to see you soon personally.
Thanks for the invitation.
All the best.
Bye-bye. Thank you.
Bye. Bye.
Registra.